Okay, so this week we learned a lot about antibiotic resistance, um, and we read a lot of articles posted about antibiotic stewardship as well. So I'm going to talk a little bit about what I've learned about it. Um, First of all, the CDC states that about 20 to 50% of all antibiotics given to patients in acute care facilities, so like the hospital, are unnecessary or inappropriate. Um, and more than anything, they have side effects such as antibiotic resistance and C. diff, which I'm going to talk about. The CDC also estimates that 2 million people are infected with antibiotic resistant organisms um, a year, which results in about 23,000 deaths, which is insane to me. Um, and then I also read in a Medscape article that about one half of antibiotics prescribed to patients are unnecessary. So, what happens is microbes will resist a drug effect, and then the infection will continue to grow, and it's not stopped when the antibiotic isn't treating it, and that's something that becomes even more of a problem and more difficult to treat. Um, so, with that said, I'm going to talk a little bit about antibiotic stewardship programs, which I learned a lot about because I actually had never heard of it until this week and started reading about it, and I think it is really neat. So, what antibiotic stewardship programs do is they help to ensure that patients are getting not just the right drug, but for the right amount of time and the right dosage. That antibiotics aren't overprescribed or prescribed for too long of the amount of time. Um, they improved patient safety through increased infection cure rates, reduced treatment failures, increased frequency of correct prescribing therapy, and prophylaxis. They reduce the rates of antibiotic resistance because we're giving the right drug for the right amount of time. Um, and then ultimately, they shorten your hospital stay and they save money. So, what do we need to do? So, one of the biggest things that I think we do is get cultures before we give antibiotics. Thankfully, my hospital is really good about doing that. Um, although patients are often started on a broad spectrum antibiotic, you come into the ED and first thing, if any sort of infection is suspected, cultures are always drawn. I don't think I've gotten a patient from the ED before where they did not draw cultures beforehand, unless we were just drawing another set later, which is really impressive. Um, and then a lot of times they will come up on broad spectrum antibiotics, just to try to rule out and kill whatever until they know what more specific antibiotic a patient needs. And that might be somewhere where we need to reevaluate um, if they're necessary. And I think that's done because a lot of times cultures take several days to come back, and so we don't know until they come back how to treat them, so it's kind of like a guess. And unfortunately, I've seen that even lead to some antibiotic resistance. But it's kind of like weigh your options. Would you rather risk a patient getting resistant or getting more ill from not having any antibiotics until cultures have come back? So thankfully, my hospital has been good at getting cultures. Um, Another thing I read about, which I actually wasn't really familiar with, I guess in this term, is taking an antibiotic timeout and reassessing after about 48 to 72 hours. So what I do in my clinical practice is if I notice a patient's been on antibiotics for several days, I always question it. I look at why they're on it. Is their white blood cell count or whatever it's affecting improving? Is it necessary? Can we switch them to PO dose? Do they seem to be working? And I always ask questions to my pharmacist and to my provider. Um, and a good example of this is I now that I'm on a mother baby floor, a lot of my previous experience with antibiotic resistance was from a med surg floor I worked on, but now I work on mother baby, and a lot of times we get patients who are on antibiotics, both mom and baby, for chorio, and that is when there's an infection. They notice an infection when the water breaks. Either it's purulent drainage, or it smells really terrible, or their water's been broken for greater than 24 hours. So we put them on antibiotics for chorio. We usually put them on what we call GAC, which is gentamicin, clindamycin, are like the two big ones. Um, and so what we do with the antibiotics that they're on, they're typically supposed to only be treated for 24 hours, but sometimes um, the physician will not actually put a stop time on the antibiotics. And I don't know if it's just not caught by the pharmacy, but I've had patients for 3 days still on these antibiotics for chorio. And I'll get the patient and then I'll call the physician or the pharmacists and ask about it, and they're always like, oh, whoops, we forgot to stop it. But that was over 48 hours of extra dosing of antibiotics that these patients did not need. And so that's another thing that I always try to do is look at how long has this patient been on these antibiotics and why. Um, so the Ebola virus. The Ebola virus has caused a huge stink in America, I know. Um, even though we've only had a few cases here, because the symptoms can lead to profuse bleeding, organ failure, and obviously death. It's spread through body fluids, not airborne like it's commonly misunderstood to do. And then the most well-known treatment that they've shown, I guess, is IV fluids, rehydrating, electrolytes, oxygen, and just time. It is a virus, so it is not something that antibiotics are known to treat by any means. Um, Several meds have been tested, and vaccinations have been tested against Ebola, but nothing has really been tested on a human yet, so they don't really know. I went back and read about several medications given for Ebola. One of the most common ones is called ZMapp. It's experimental right now, but it's a drug that has several antibodies in it, that's been developed, and it was tested in 2014 actually in West Africa, and they don't really know if it works, but they think that it might have worked for a couple people, but they're not actually sure if that's what treated them. Um, it's still under experiment, like I said, but it is something that they're using as more mainstream, or they want to be mainstream treatment for Ebola virus. But what has happened with the Ebola virus is that people will come in and a physician, they have symptoms like they're throwing up, they're nauseous, they have a fever, symptoms that could possibly be something related to Ebola, and everyone freaks out because we're in America, especially. So when stuff like that happens, it's common to over treat just in case. I've seen physicians order like vancomycin and all this stuff just in case. And in reality, if it's a virus, that kind of antibiotics aren't going to help. So we need to make sure that we are being very careful with these patients and recognizing what their symptoms really are, if they truly need an antibiotic or if this is strictly viral. Um, and as new drugs are developing for the Ebola virus, I think it's just important that we really learn about them and learn what they're supposed to do and why they're given, and understanding what a virus is as opposed to a bacterial infection, and always practice with a questioning attitude. That's one thing that I've definitely learned um, working in the hospital. Thank you guys.